Good morning, everyone. I'll be talking about Saga of a White Pearl. So we'll be discussing a case of a 7-year-old girl who presented in my OPD with the nodular swelling in left eye, upper eyelid since 4 months. So there was no other history of childhood trauma or any surgery, no significant past history. On local examination, she had left eye, upper eyelid progressively increasing swelling, which was measuring around 1 by 1 centimeter since 4 months. The swelling was firm in consistency and was painless and immobile. There was no other signs of inflammation. There was no edema, erythema. Extraocular movements were full in all directions, and other eye was unremarkable. We asked for a previous picture from the patient, and she presented a picture with which was 3 months before the presentation. There was left eye, upper eyelid swelling, and there was no eyelid edema or erythema. There was no proptosis also. So a clinical diagnosis of left eye, upper eyelid dermoid cyst was made. We asked the patient to get a CT orbit done, but patient already had got the scan done, and she was there with the report, and she didn't get the films with her. So impression of left eye internal angular dermoid was there, and rule out orbital component was written out there on the report. We planned for a left eye excision biopsy under general anesthesia, and patient will bring the CT scan before the surgery is scheduled. On CT scan, we could see a well-defined hypodense, thick-walled ovoid cystic lesion measuring around 7 by 9 by 10 seen in the left eye upper lid anterior to the globe. There were no calcifications, perilesional infiltration, intraorbital or intracranial extensions were absent, and bilateral optic nerve and globe appeared to be normal. So blood investigations were done, and differential diagnosis of epidermoid cyst, dermoid cyst, cysticercosis or hydatid cyst was made. But on the day of surgery, patient presented with the inflammation on pain on the nodular swelling area, and there was inflammation on that area. So impression of inflamed dermoid cyst with thinned out skin overlying the lesion was made. So patient was asked to wait for the inflammation to subside and follow up after 1 week. After 1 week, when the inflammation was subsided, but then there was thinning of the skin overlying the lesion, and there was no tenderness, so we planned to continue the treatment for 1 more week. After 2 weeks, when patient came to us, she said that there was bleeding from the lesion and showed the discharge which they have collected on a piece of paper, which appeared lot to be like a cyst. This was the discharge which she had collected. We sent it for the biopsy, and we could see a cystic cavity containing a larval form which had hooklets, and there were autolytic changes. Also, there was no malignant cells or any changes like that seen. Impression was made of a cysticercus cyst. So the diagnosis, we went back to the previous pictures. This is the picture when patient previous to the presentation 3 months back. There was a swelling which was seen in the left eye upper lid. Then this is the picture at the time of presentation. Eventually, when patient had inflammation on the day of surgery, and the day when there was extrusion of the cyst. So we reviewed the CT scan, and in this CT scan, in one of the slides, we had missed this hyperdense opacity, and also we had missed eosinophilia in the patient. So a clinical diagnosis of cysticercus left eye upper lid with spontaneous extrusion was made. So coming to the treatment of this, so complete evaluation for any other cystic lesion was made, and patient was treated with oral albendazole 15 milligram per kg body weight. Maximum dose of 800 milligram OD was given for 6 weeks, and oral steroids alongside prednisolone 1 milligram per kg was started. So this is the picture after 3 months. So this was the first picture is with on the day of presentation, and the second picture is after 3 months after presentation. So cysticercosis, coming to the topic, it is larval form of Taenia solium, which is and human being the intermediate host. Contaminated food and water are the source. Approximately 50 million people worldwide are infected, and around 50,000 come to death annually. Sites of cysticercosis, CNS being the most common and subcutaneous being the least common. Ocular and adnexal involvement is around 1.8 to 4.5 in Indian population. In India, 78% of cases are seen in the states of Andhra Pradesh and Pondicherry. So incidence of ocular cysticercosis, 35% occurs in subretinal space and 1% in orbit. A life cycle, as we discussed, human being the intermediate host and oral route being the commonest, pig is the primary host. So the stages of cysticercosis are live and vascular stage, where there is a living cyst with well-defined scolex, minimal or no inflammation. Colloidal or vesicular is the mysterious stage where the inflammation starts. The cyst becomes leaky and releasing toxins. There are varying degree of inflammation which can be noted. In nodular granular, the calcification starts and the edema or there is decreased enhancement. Initiation of calcification is there in this stage. And then calcified stage, where we can see rounded whitish calcified nodules. In orbital cysticercosis, extraocular muscle form is the commonest, where medial rectus is commonly involved, and our case is an isolated eyelid cysticercosis, which is around 0.6% of incidence. Subconjunctival space followed by eyelid, optic nerve, and retroorbital space, lacrimal cysticercosis. These are the order. So presentation could be periocular swelling, proptosis, ptosis, pain, diplopia, restriction of ocular mobility, strabismus, lid edema, orbital cellulitis like picture, and subconjunctival presentation could be there, which is secondary stage, might be the cyst has extruded from the primary extraocular muscle site. So diagnosis can be confirmed by serological test, but which may show false positive reports. Imaging are very definitive, where we can see a hyperechoic scolex on a B scan, and A scan also shows high amplitude spikes, whereas a CT scan or MRI are definitive, where we can see a hypodense mass with the central hyperdensity, which is suggestive of a scolex. Other tests are, in our case, there was eosinophilia, which we missed previously, and stool examination can also be done. So management of orbital cysticercosis, in case it is subconjunctival cyst, excision biopsy, and then evaluation of any other neurocysticercosis should be done, and neurological examination followed after that. In case there is proptosis, restricted motility, inflammation, or ptosis, then CT scan should be done for neurocysticercosis or intramuscular lesions. And in intramuscular lesions, we have to see for the scolex. If there is scolex, then we have to start the empirical therapy of oral albendazole and oral steroids. In case there is no scolex, then ELISA should be done and pursued eventually for if it is positive or not, and diffuse myositis should be seen. So this is the empirical therapy which should be started, like oral albendazole, maximum dose of 800 milligram OD, and oral steroids alongside. Medical therapy is recommended treatment for extraocular muscle and retroorbital form of cysticercosis, surgical removal only for subconjunctival or intraocular forms, and treatment of optic nerve and lacrimal gland cysticercosis is still controversial because of limited number of cases. So take home message in my case would be, a location of cysticercosis varies. Non-tender subcutaneous lesion in the patient of low socioeconomic status with typical imaging finding can prevent dreaded CNS complications, and treated with medical therapy gives complete resolution if instituted timely. Thank you.
Okay. Nitish, if you had suppose seen that CT scan carefully and in first go only you could have made that a scolex, would you have gone for surgical excision, or since it's an accessible site, or the medical therapy only?
Yeah, probably we could have gone surgically also, because it is very accessible. Yeah, we could have done that. But then it was inflamed on the day of surgery, so we postponed the surgery on that day, and then eventually when the patient came with the extrusion of the cyst and got the cyst alongside, so biopsy confirmed it all. We also scanned for other cysts in the brain or somewhere, but there was no other, but still we went for the empirical therapy. I didn't get you, ma'am. Yes, ma'am. It was continued for three weeks. 6 weeks we continued the albendazole, but inflammatory stage alongside, when we continue albendazole, there is inflammation with the cyst also. So if the cyst is dying due to albendazole, then inflammation is there. So to take care of that, we start steroids alongside.
In a tapering dose, right?
In a tapering dose, definitely.
Very extensively covered cysticercosis topic by you.
Thank you, sir.
Excellent. Didn't you do B scan in this case?
Sir, actually patient already had a CT scan report,
okay.
So we didn't actually. Yes, yes, ma'am, definitely. Yes, sir. Yes, ma'am. Yes, ma'am.
So we have to, yeah. We have two learning pearls out of this. that even after you have a scan with you, CT scan, you should also think about the B scan.
B scan.
And second thing, we should have patience that you kept throughout the saga.
And one more learning part, revisit the CT scan again and again. Sometimes we keep
We
on
tend to
misdiagnosing.
miss, yeah.
We miss a lot. So we have to visit it.
Yeah.
We asked for the non-vegetarian diet
At
as
times, but at times it is not always true for all cases. Yeah, we should
But
ask.
in this case, the typical position of an angular dermoid, and the imaging was there, and there was a previous picture which was shown, and in the location, the incidence of eyelid cysticercosis is 0.6%. I have shown a previous picture which was there 3 months before. Yeah,
Cyst might have migrated.
migrate. Thank you, ma'am.
Thank you.
Thank you.